This program is to talk about health habits, some facts that everybody needs to know, some new things, some old things. Some of this you'll know, some of this you will not, but I hope you'll enjoy it and take away something you can use at home. You know, and I've discovered that most of the people that come to health talks are pretty savvy already. They've had relatives or they've had health problems. So what I really want from you is I want your relatives and your friends. I want you to connect to them with information that you may get tonight. If you see things they're doing that are hurting them, please connect with them and try to help them change that. Now this is a picture of a CT scan of a heart, and this is the way you can modify this, give it all kinds of colors, but you see the arteries on top here. This is the right ventricle, the pulmonary artery, and I can't point everywhere, but I wanted you to see this because a few years ago, as the CT scanners got faster, we became able to take pictures of the heart in ways that we couldn't do before. Now, the next frame is going to be a picture of a beating heart, because again, I want you to know your heart a little better and see it so that it, Whitney wanted me to warn you, and if you want to turn your head away, you can. From what people see on TV, I don't think any of you will have problems with this, but anyway, Whitney, we're good. Because the heart is usually kind of abstract. You can't rub it or touch it or feel it. So I want you to know what it looks like because it's in there. And this is what we have to take care of. Now, your heart and this heart, it beats over 100,000 times in a 24-hour period. Over 100,000 times. It pumps over 50 gallons every hour. Over 50 gallons every hour. And it does that for decades and decades and decades. But it needs help sometimes. And that's what we have to try to do. Now, obviously we're going to talk risk factors. One of the biggest is smoking. Kills many people, both from lung cancer as well as heart disease. The smoking incidence is falling in the US, but it's still climbing worldwide. In this country, from these studies that I've reviewed, 2 to 3 times the risk of a coronary event like heart attack, unstable angina, sudden death from the patient that does not, for the person that does not smoke. Now these are just some data. If you smoke, it depends on when you quit. You know, if you quit early, you live a lot longer. If you quit late, then you don't save as much time, but you do save some time. So if you stop at 60, you save 3 years, maybe 3 years extra life. If you stop when you're 35, then maybe up to 10 years. High blood pressure. Unbelievable number of people with high blood pressure. The numbers just were staggering to me worldwide. Almost, 972 million in 2000, projected to be 1.5 billion by 2025. Untreated hypertension can shorten your life 10 to 20 years. Only about half the people with high blood pressure know they have it, and about half of those are inadequately treated. So it's a big problem. Even if you have a mild elevation, it can shorten your life. This, I don't know if you can see it well, but I wanted you to see what your doctor sees. This is your cholesterol panel, so we're talking cholesterol This is one of the other big risk factors. He sees your HDL, which is your good cholesterol, and the lab work gives you normals, high and low. It gives you your bad cholesterol, the LDL, gives you a risk factor index, gives you your triglycerides, and it gives you your cholesterol, total cholesterol value. Now, the other thing you may see on some reports is a VLDL, which some doctors use, some don't, but the main things that are used is the bad cholesterol, the LDL, and the HDL and the triglycerides. This is called a coronary calcium score. It's a very brief CT scan, and it's a way of non-invasively identifying plaque in your arteries. Okay, now this is the report over here, and this is a picture of a coronary artery, and you'll notice these bright spots, that's calcium in the plaque in the artery. Okay, now again, this is a CT scan. It's very brief. It's about 5 seconds. It provides us, we're able to measure these, the amount of calcium, and it gives you a unit down here at the bottom, which you don't need to worry about, but it does measure how much calcium. And by doing that, we're able to tell in a rough way how much plaque you have in your heart, in your coronary arteries. Coronary calcium score. This is a test that I think is underutilized. There's no risk to it. You don't need a doctor's request or order for it, and you can get that just by calling the radiology department and saying, I want one of these. In this state, you have to pay for it. Your insurance will not cover it, but it only costs about $150 to $200. Sometimes in February they have a special. So anyway. Diabetes is another huge risk factor. You know, here some numbers, 7% of the population. And among people with diabetes, the heart disease is the leading cause of death. 70% will die from heart-related causes, cardiovascular causes. Women's risk is a little higher, and diabetes imparts a 2 to 8-fold increase in incidence of cardiac events in the diabetic population. So it's a big deal, diabetes is. Now, this is something that I'd like you to be aware of. It's called the metabolic syndrome. It is a combination of things, but one of the most prominent parts of it, and you may have heard about this, is it's the truncal obesity, the round stomach. Arms, legs are pretty good, but they're just big in their trunk. As opposed to the pear shape. These are women. We could have done men, but we borrowed this. The normal pear shape is just different. And part of the diagnostic criteria for the metabolic syndrome relates to waist size. So that if you're a man and your waist is over 40 or 45 inches, or a woman and it's over 30 inches, then this may apply to you. You have some increase in your triglycerides. Your HDL is down in both men and women. The blood pressure is up a little. Serum glucose is up a little. And this is basically kind of a pre-diabetic condition. Now I'm going to introduce these initials, CRP. That's C-reactive protein, and that is an inflammatory marker, a test that we're doing and have been doing for several years. It's not that specific for heart disease, but it is a predictor of risk of future events, so that a lot of us are using CRPs just to try to establish someone's risk for the development of vascular disease. The reason this is such a mammoth problem is that it affects 25% of our population. Can you imagine how big that is? It affects 10% of adolescents. It's really scary. It's really scary. Somehow we've got, as a culture, we've got to change this, because if all of these people become a diabetic or develops, hypertension, with the risk of cardiac disease and all of the other things that comes with long-standing diabetes, it's just a terrible thing for the culture, and we'll just have to deal with the aftermath. But again, I wanted you to understand that, because it's something that doctors deal with a lot and think about. Now, age, that nasty word. We had some fun finding the pictures. I hope this picture fits you to some degree. The older you get, the higher your risk. Now, when I turned 60, my risk of an event probably went up to 40%, or 40% above what it was when I was 25, even with minimal risk factors. When I get to 80, it'll be even higher, just because I'm older. So there's an element of aging that you can't get away from, okay, no matter what you do. So we just have to accept that and go on and do the other things better. Now, this is on, again, I wanted you to understand this relates to obesity, and it's a little out of order, but I wanted you, when you're reading and learning about this, kind of how we look at the size of each other. We use something called a BMI, a body mass index, and the way we get that is we take the weight and divide it by the square root of the height. So it adjusts for someone that's 200 pounds, whether he's 5'2" or 6'2". So it's called a body mass index. And this is your normal. So if you do your BMI and you're under basically 25, that's good. You're in a normal weight range, okay? Because a lot of people ask me, what's my normal weight? And you can't do it. Just say, well, you look, 140 pounds, that's about right for a 5'6", This is much better, and this is how we do it. If you're overweight, 25 to 30, basically. If you're obese, 30 to 35. Now, you may have read that in terms of the obesity problem, that probably 30% of our population or greater is obese. In certain groups like Hispanics and blacks, it's even higher than that. But it's something we just have to work on as a culture. Then the severely obese, 35 to 40, and then if you're over 40, then we have a lot of work to do. The obese individual, because I'm trying to bring this back to life and how many years you can save if you do certain things, or if you can be certain ways. And I will tell you ahead of time that hundreds of articles and a lot of research has gone into all these risk factors, trying to see how it affects lifespan, your life expectancy. Because we all want to live longer, we want to live better. So I've tried to give you, when I could, numbers that would relate to years, okay? And you've noticed I've done that in some of the earlier slides. An average obese individual, that's 30 to 35 BMI, right, lives 7 years less than average. That's pretty staggering to me. A severely obese individual lives 10 fewer years on average. Now you may, again, these are averages, but this is a big deal. It makes a big difference, how you do your life. And I don't have a lot of jokes, but I thought this was cute. So anyway, you know, we almost have too much good food to eat. The grocery store to me is the most fascinating store we have. I don't go there often, but I'm always fascinated by it. Okay, exercise. Now, this is also a big deal because as we exercise, our weight comes down, our diabetic incidence falls, our cholesterol improves. So we reverse a lot of the things that we're afraid that were going to cause us problems. 25% of the population has no leisure time physical activity. Amazing. Women are less active than men. So ladies, if you want to be on top, you got to run harder. You've got to do more. The risk of coronary heart disease, and when you see CHD, that means coronary heart disease. That's artery blockage in the arteries of the heart. Cholesterol blockage in the arteries of the heart. CHD. Okay, the risk of heart disease is 50% greater in sedentary individuals. 50% greater. You know, this really hit the press back in the 50s when they compared event rates in people that were trained conductors versus the ones that took up the tickets that were moving all the time in the trains. Also compared bus drivers to people that were moving. The Longshoreman study out in San Francisco, you may have heard about that again many decades ago, but it really put the emphasis on activity and health. And I just wanted to emphasize that. Now, if you take an individual that is very sedentary and you just get him to do a little bit, so he goes from from none to just mild activity, his event rate improves dramatically or drops. Okay? That's the biggest difference as opposed to someone who has a mild activity level and goes to moderate. He doesn't gain as much as the guy who doesn't do anything and goes to some exercise. And the person that goes from moderate to high levels of activity gains even less, but still some. But it really is, if you can get yourself off the couch and moving, and what we really recommend is 30 minutes of continuous activity. Continuous activity, at least 5 days or more per week. Okay? Now, some of the studies that really touted the effects of exercise, that was 1 hour of exercise every day. I don't know anybody that can do that or will do that, at least in my friends, among my friends. Everybody's working. You just don't have enough time. It's a tremendous commitment to do that, but 30 minutes, you know, 4 or 5, maybe 6 days a week, I think is doable, but you really have to plan for it. And if you can do it, there's a great deal of benefit from it. Your cholesterol gets better, the panel, everything is improved. Your HDL, which is the good guy, goes up. Your bad cholesterol drops, your triglycerides fall, blood pressure drops. It's a big difference in blood pressure. Your weight drops, you have better diabetic control, you improved insulin sensitivity. These inflammatory markers that we talked about will fall. It's fascinating to me, the chemistry, the change with activity. And you feel better and you look better. Just makes a big difference. But it really, it's hard to stop smoking, it's hard to start exercising. All of this is difficult, but you can do it. Everyone can do it. Now, dietary recommendations, this is a rough guide, and my orange looks a little like something out of a horror movie, maybe. But basically, fruit are big, you know, antioxidants, vitamins. Try to eat fruit every day. Vegetables are big. Pile them on. Low saturated fats and no trans fats. Okay, now trans fats are just unsaturated fats that have some different molecular structure that has been shown to increase cardiovascular events, and you want to stay away from those. And everybody's pretty aware, and it'll say no trans fats, so that's good. Balance your calories with your activity level. Okay, so if you don't do much, don't eat a lot. If you do a lot, eat a lot. So balance it out. Refined sugars and carbs, we all love something sweet. Cookies come with every meal almost. Try to balance that if you can. I won't say not eat it at all, but anyway, everything in moderation. This is a big deal, no supplements. Dark chocolate's fine. Supplements that everybody's interested in, coenzyme Q10, I hear that a lot. Fish oil, which maybe we'll get some questions about. There may be some other supplements and weight loss items that you want to mention or talk about. Those are not really prevention type things, okay, items. Just the basics. Fruit, vegetables, lean protein, and plenty of it. Now this is something that I think we probably don't emphasize enough. Depression, social isolation, unhappiness actually increases events, cardiovascular events. Treatment will sometimes lower those events. So it's a risk factor. There are some novel risk factors that have been looked at that we are on again, off again with. One is the high sensitivity protein measure, the CRP, I mentioned that. Homocysteine values, if your homocysteine is high, that's been a concern. At this point, it really has not been shown to affect outcome greatly, but it's still of some research interest, and some physicians will still measure it. Lipoprotein, little a, has been around a good while. It's still something that hasn't shown to impact outcomes like the other risk factors like weight, cholesterol, and smoking, and high blood pressure. Now, how do we live? You can't live forever, okay? We just want to live a long time and live good. And these are some things that I think that if we did more of, that we could do that with. Pick your parents carefully. It's very important. That may be the most important thing. Okay. Maintain a good body weight. Exercise. Optimal lipids. Have good cholesterol values if you can. And I tell you, we've got a tremendous armamentarium of medications for cholesterol, so that most people can be carefully controlled, and we can reach goal, which is how we say it, reach the goal of cholesterol targets. And so you just have to work at it, and you've got to know what it is and try to eat right and communicate with your physician, because he's got the tool. Eat wisely. Control blood pressure in your diabetic state. Be happy, and use your seatbelt. So, there's some other things, internationally to, for long life, such as infant nutrition and all of the clean water stuff, which we won't go into, of course. But this is just a handful of things, and it's not everything. I mean, you have to do some other things too, but these are some of the very basics that will mean a lot to your life if you can do them. Now, I'm going to switch horses and go to what's new, because I've shown you a lot of the old, and I've updated some of the things that you knew, and I hope I've triggered some interest and some ideas. But medicine is always changing. And I just thought I'd share with you a couple of things that I think are really pretty neat, gadgets and treatments that you may or may not have heard about. Now this, to tell you ahead of time, is called a TAVR, T-A-V-R, transcutaneous aortic valve replacement. This is the ability to replace or to place an artificial valve in a beating heart with a catheter, okay? So that you don't have to have a big operation here. This video shows you the placement of an aortic valve it's a graphic representation for aortic stenosis, which means the leaflets just don't open fully. The reason this particular lesion is so important is many people, as they get older, the valve wears out. And when it wears out, it stiffens, and then it tends to calcify, and then it gets even then stiffer, and it just won't open. It should go like this and open, but it just goes a little bit. So what the technique aims at is taking a 90-year-old who might have this, or a 94-year-old, or an 85-year-old, and who would be at high risk for surgery, and been able to do this with a catheter without an incision. The very first few frames is an actual patient, an actual procedure, and then it'll show you the cartoon. Now this is the valve right here. All right, now watch it. Now the balloon's going up, it stretches it, pushes it against so that it seats there at the annulus of the aortic valve, and then the balloon deflates and they take the catheter out. Now this is the valve that's diseased. See, it just doesn't open fully. It's little pebbles of calcification there. And a catheter first goes up. It's done from the leg, from the femoral artery, goes up over the arch, crosses the aortic valve. That's the guide wire. And then the catheter comes up. It's got a balloon right here. Okay, now they blow the balloon up, breaks it, opens the commissures so that it opens, and then they take that out, and then they put another balloon up that has a stent valve on it. It's loaded on the balloon so that it goes across, comes around the curve, goes across. They'll blow the balloon up. There's the balloon. And see, then the balloon collapses and they take the balloon out and they leave the valve in place. Okay? And they'll show you what the new valve looks like. From the top, just like we saw the other one. It's very cool. And that's what the new opening looks like. Isn't that neat? Now it's almost ready for prime time. We're not quite there. Emory has had several early trials, and they're in their second one now. It's just very exciting. I think Tallahassee is starting under protocol, which means as part of a study to do this within the last few months. So it's really neat. Okay. Now this is a picture of a new defibrillator. Now, does everybody know what a defibrillator is? It's those fancy pacemakers that if your rhythm gets out out of sorts and goes too fast, it will shock your heart and get it back in rhythm. And it works fine if you have access, but a lot of the patients, particularly dialysis type patients, lose their access. Their veins get beat up from all the catheters that have gone in, and it gets blocked, and we have no way really to access the heart with a defibrillator. So this is a new type defibrillator that is strictly subcutaneous. It doesn't go in the heart at all. Okay? It is tunneled under the skin from the axilla over here where the generator or can stays. It's tunneled to the center and then up. Okay? Right like this and then up. And again, this is all on top of it's under the skin, but it's on top of the rib cage. Okay? So that you don't have any catheter or any hardware inside the heart to do this. Because, up till now, all the pacemakers and defibrillators required us putting a wire or a lead inside the heart so it could sense and pace and defibrillate. Well, this one, for those patients that can't take that, is external. Now, and it's really quite comfortable. We got our first patient back from Emory a few weeks ago, and she said it really was very comfortable, but she hadn't been shocked by it. When this thing shocks you, the output's about 3 times what the other one is. So, because you have to go through the chest wall. So it's a pretty good kick. But it's very recent, and I just wanted to show you a picture of it. I thought it was really neat. People are coming up with gadgets all the time, and it's hard to keep up with everything. So, now this is a list of some things that I wanted to mention that are new. This genetic testing for drug therapy. We've been hearing about, designer medications for a long time, and by that I mean if we can test your DNA and find out how you metabolize a drug, then maybe we'll know early whether it's going to work for you or not. Okay? You understand that? Well, a company, we had a representative from one of the companies a few weeks ago that came in, and that's what they had. I was amazed. You take a buccal swab and get some cells, therefore you get some DNA, and they send it off to their lab, and you tell them kind of what drug categories you're interested in, and I would be interested in things like Plavix or some of the drugs we use for irregular heart rhythms, how those are metabolized. And then they send you back information about how they metabolize the drug and whether they think it would be a good choice for you or not. Now, this is really early, but my thought was, geez, the future is here, That's where it's going. It's going molecular for much of medicine. Cell therapy. I wanted you to hear about that. It's been, that's the process in which you try to get certain early cells, primordial cells, or cells that from your bone marrow that have not differentiated or changed into a specific cell type, like a muscle cell, or something for your eye, or something, hair, or something. But if you get them early and try to get them to move or localize in an organ, and then try to get those cells to differentiate into new cells for that organ. Is that clear? So we're trying to get cells from the body to move to certain parts of the body and differentiate so that it will help to renew the cells of that organ. Okay? So that in the heart's case, if you've had a heart attack and you have some scar or weak muscle there, we're trying to get some new muscle to grow there. Okay? And that's called cell therapy. And there are lots of, there's much research around the country trying to establish how to do that. People have tried injecting it into the coronary arteries. They've tried injecting it directly into the heart muscle, externally, and also through a catheter. And it's very exciting to me, and we don't have all the answers yet, but it's something to watch out for, and maybe in the future, not too distant future, we'll have the ability to do that. Now, how many people in here have a smartphone? Is that okay? Well, the smartphone is pretty amazing. I had one of my nurses send me a little website, and it was fascinating. But here at the bottom, there are some new applications for smartphones, and this one was approved that you see here. This is a smartphone, and this was approved last November or so, December. It turns your smartphone into an EKG monitor. Okay, it's just, anyway. You have to buy this little thing, I guess, to hook on the back of it, and you have to put a little piece on your chest, but then you can sit there and watch your heart rate, you know? And then I guess you can just hit the button and transfer it to your doctor. Say, look, I found all this bad stuff, all this good stuff. The other thing that, and there are lots of things, just the other thing that fascinated me was there was a little adapter that kind of stuck on the stomach, and I couldn't tell from the video that I saw whether it actually pierced the skin or not, so I don't know that, but he was able to read his blood sugar real time on his smartphone, you know, without sticking his finger 4 times a day or 3 times a day. I mean, and I don't know how you do that, but it was fascinating to me. But I think that the technology is going to take us places like that. The other thing they had with the smartphone, you know, we spend hundreds of thousands of dollars on equipment. And one of the pieces of equipment that we use a lot of is an ultrasound machine called an echo machine. And I want you to know, they had a smartphone hooked up to a transducer and taking pictures of somebody's heart. I mean, there must have been another piece to it somewhere, but it just floored me. So I have more respect for the smartphone. I was a BlackBerry fan for a long time, but anyway. So, you know, things are changing. You know, for our generation, some of this high-tech stuff's a little complicated. Big challenge for us. But there's a lot of good stuff coming. So watch for it. Some of it will pan out, some of it won't. I want to go to my next and last slide. Jim Story, whom I'm sure most of you know who he is, invited George Sheehan to come be with us and talk to us and lecture for us in the early 90s. Dr. Sheehan is a physician, a big runner, exerciser, and a philosopher, and he just was a wonderful fellow. And has written several books on exercise and other inspirational topics. And I just wanted, this is just a quote from him, and I thought it was in terms of our search for better life and longer life that I would include it here at the end. Health makes for the happy pursuit of happiness, and it gives us a longer time to do it. Thank you very much.
Dr. Ellis, you mentioned a little bit about the TAVR or TAVR, T-A-V-R.
Yes, TAVR.
Is there any estimate when it will be readily available, maybe here in Thomas School?
You know, I think it's going to be a couple of years. You know, we're very excited about it, but it's going to be several years, I think.
Thank you.
I have a question about supplements. You know, we hear a lot of studies about omega-3s and all
Right.
and why you said no suffering.
You know, and I use fish oil, omega-3 fatty acids for specific things like elevated triglycerides. I really like it for that. You know, it's been touted to have effects on heart rhythm. It has effects on blood vessels in terms of how the lining reacts, and it's called the endothelium, and that's a big deal with vascular patients. It has, in some, I think, circles, maybe some benefits with aging. And there's some data suggesting that it may reduce events, but it's not a consistent finding. So, you know, for me to tell you that everybody in here should take, you know, a gram of fish oil once or twice a day, and certainly not 2 grams twice a day. That's a pretty big dose. I think it's a useful tool, and with certain indications, I think it's appropriate. I have a lot of patients that just take it because they think it makes them better. But I have trouble finding, you know, enough data for me to tell you that it's going to extend your life and reduce your chance of heart disease. If you know, have some of the issues related to lipids and things. That story is kind of evolving, and we'll get more of it later over time, but it's intriguing, but I don't think we have all the answers yet. It usually will not hurt you. It does thin your blood a little bit, so that if you take a lot of blood thinners or these dual antiplatelets, you certainly wouldn't want to take high-dose fish oil. But I think it's something to continue reading and learning about.
The CT scan at radiology said diagnosed calcium deposits. Does it also diagnose cholesterol deposits in all these?
The calcium occurs in the cholesterol plaque. So it's the calcification of the plaque that we're seeing. So that's why it's important.
So why can't everybody come out and do that? Because usually it takes a life-threatening incident to...
Well, I don't think you ever want everybody to go out and do it. But I think it's underutilized, but we like it, particularly in the person of intermediate risk, not necessarily the low risk, which would be a 38-year-old female who runs 10 miles, you know, every week.
But if you say you meet 3 of the 5 criteria for high risk, that would be mighty well studied.
Yeah, absolutely. Especially if you're in your 50s or even 40s, have some family risk, you know, early heart disease in your family. You know, it gives you information that you would not have otherwise. It does not replace the angiography or the angiograms or the dye tests that we do. This does not diagnose what we call soft plaque. That's plaque that is not calcified. So in absolute terms, if you have a 0 calcium score, it's pretty close, but it's not 100% that you don't have any blockage. Understand? But it's a poor man's way of getting a kind of a quick fix. You know, if you're doing great and you're healthy, but you have, maybe your dad died at 59, you think, well, you know, I'm 50-something. I think I'll see if I'm building any calcified plaque. So, and it helps your doctor. Sometimes you're really surprised that somebody of low risk, that is few risk factors, has a lot of calcium. Okay? And it helps to focus the doctor and the patient on prevention. It's very important. So I think it's a good deal. You know, It's a wonderful application that we just don't do enough of, I think.
Doctor, on the subject of cholesterol medicine, over the years from friends and family, I've heard a lot of negative feedback about the consequences or detriments, almost being at a level where they would outweigh the benefits that are received. Could you talk a little bit about that?
Yeah, this is a real problem for us because the statins have been an unbelievable asset in the fight against heart disease. The presence of the most frequent side effect are myalgias, sore muscles and joints. And that goes away when you stop it in almost every case. Occasionally you can have, or rarely you can have a very serious inflammatory muscle response that I've never had a patient do, but you can't, it is reported. The part that patients generally are most anxious about, though, relates to the liver and effect on the liver. And that's pretty rare. Normally, when you get your cholesterol checked, we get a lipid profile, a liver function profile with it, so that if your liver enzymes go up, then we cut the dose back or stop the medicine. So it's easily managed, and it's only about 2% of the patients on the drug that have any enzyme changes. Very small amount.
Dr. Ellis, when you're sitting still and not doing anything, and when your heart stops beating real fast for 3 or 4 minutes, what's causing that?
That's called tachycardia, and it's it could be a lot of different rhythms, but usually it's called a supraventricular tachycardia, and probably everybody in this room has had that happen at one time or another. It's usually not threatening. It is a nuisance. If it persists, it can be threatening, especially if it goes 180, 200 beats a minute, 220 beats a minute, which it can do. If you have heart disease, like you've had a heart attack and had damage or have a weak heart, then episodes like that are much more significant in terms of threat. So you need to be checked and, get a recording so we can see what it's really doing. It's interesting that we see a lot of patients with that, and we call that palpitations. And about half the time, when people think that their heart is pounding and beating, it's actually not, and it's something else. Interesting, because we get body movements and sensations that.
Doctor, what is the cause that make blacks have high blood pressure? Reduce the niggas have
Increase. I don't know. I don't know. I wish I could help you, but it's just a bigger problem and needs to be aggressively identified and treated.
How often should you have an EKG if you don't have symptoms?
Probably only when your doctor does his physical exam, either annually or depends on how young you are as to how often you get it. If you're normal, you don't really need an EKG very often. Periodically, it varies according to age and what your other health problems are. In our heart patients, I like to, at least get one at least once a year, just to update their file in case something has changed. We frequently are doing more echoes, which are non-invasive, no radiation, no needles, to reassess function, which changes. And the longer I do this, the more I'm amazed at how everything is changing, And you have to update, your data so that you know if that person's function has actually declined. That's real important information to us. Stress tests are critical. Sometimes in high-risk patients, we recath patients periodically to check on progression of the cholesterol plaques. But everybody's different and every situation's different, so it's a little hard, but I think most people, once they start having annual physicals or every couple of year physicals, that I think an EKG ought to be part of that.